welcome to the Preemie Chats, and thank you for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, as known as CPBF. We are a charitable organization, and our mission is to empower families of premature babies through support and education. This Preemie Chat series is one of the many initiatives we have to bring information for NICU families and healthcare professionals. Here every Friday, we talk with experts, researchers, and parents who share with us the experience and knowledge. Also on our website, canadianpreemies.org, parents will find all kinds of resources and support. And today we are going to talk about breastfeeding self-efficacy in the preterm population, clinical considerations for enhancing parental confidence in breastfeeding. Breastfeeding self-efficacy is reflective of a breastfeeding parent's confidence and is a modifiable factor that can improve breastfeeding outcomes. Parents who have high breastfeeding self-efficacy are more likely to successfully navigate challenges and barriers with breastfeeding. However, until recently, breastfeeding self-efficacy was only explored with mothers of full-term infants. In this presentation, we explore how breastfeeding self-efficacy relates to parents of preterm infants and discuss how healthcare professionals can work with them. And I have here join me live from Calgary, Dr. Merilee Brockway, who is a PhD registered nurse and international board certified lactation consultant with expertise in maternal-child health, infant feeding, and patient engagement. She completed her PhD in nursing at the University of Calgary, examining maternal breastfeeding self-efficacy and infant feeding outcomes in moderate and late preterm infants. Merilee completed her postdoctoral training at the University of Manitoba in Dr. Megan Zazado lab, exploring clinical application of donor human milk for preterm infants. Merilee is now, actually today is her first day as an assistant professor at the University of Calgary, and is also developing a program of research examining the use of human milk as a clinical intervention to mitigate early life perturbations to the infant microbiome. Merilee, thank you so much for joining us here today, and congratulations.
Thank you, Fabiana, and I'm excited that this is my first official presentation as an assistant professor.
It is amazing. So let's share your slides, and for all of you watching us live, please do send your questions, your comments, and you address them at the end of her presentation. Merilee, the floor is yours.
Excellent. Thank you, Fabiana. So as Fabiana mentioned, my PhD work was predominantly around breastfeeding self-efficacy, specifically in mothers of late and moderate preterm infants. So I've compiled in this presentation the body of research around breastfeeding self-efficacy and looking at it particularly for families with preterm infants. And then I have some slides to discuss how we can enhance breastfeeding self-efficacy while families are in the NICU setting. First, I just want to indicate that I don't have any financial interests or affiliations to declare. As a postdoctoral scholar, I was founded by the Garfield Weston Foundation and MyTax. And the research here that we're presenting today is funded by Alberta Innovates and Alberta Strategy for Patient-Oriented Research, as well as the Alberta Children's Hospital Research Institute and the Greater Phi Care Study, which was funded by the CIHR. So what I would like to do today is really talk about the three objectives here to describe breastfeeding self-efficacy theory. Then I want to demonstrate how breastfeeding self-efficacy can improve breastfeeding outcomes. And then finally discuss how we can improve breastfeeding self-efficacy for families in the NICU. So first, let's discuss what breastfeeding self-efficacy theory is. Self-efficacy in general has been used lots in the medical field. It's a change theory that clinicians can work with people who are looking to improve in their lives or change some aspect of their lives. Smoking cessation was a popular use of self-efficacy theory. It was originally developed by Albert Bandura. And really it looks at, he says, in order to succeed, people need a sense of self-efficacy to struggle together with resilience to meet the inevitable obstacles and inequities of life. And when we put that into the context of breastfeeding, we know there's many obstacles that we can come across when we're trying to develop lactation and human milk feeding and breastfeeding in infants. So Cindy Lee Dennis adapted the self-efficacy theory to particularly relate to breastfeeding in the 1990s, because she was really seeing that there wasn't a lot of theory around breastfeeding research, and thought that self-efficacy would be applicable to breastfeeding. So essentially, what she did is she looked at the 4 sources of information for self-efficacy theory and translated them into a breastfeeding context. And what I have here in this slide is it looks at the 4 sources, the first being performance mastery, and that is successful or not successful things that have happened in your experience with breastfeeding. So if you've breastfed a baby before and it went well, or if you breastfed a baby before and it didn't go well, if you've successfully latched the infant, and how much milk you're producing. Those are all performance mastery items that can inform your self-efficacy. The second source of information is vicarious experience, and that comes along with being exposed to breastfeeding and human milk feeding, seeing other people breastfeed, seeing other people pump, essentially normalizing that experience, and also sharing your experience with other breastfeeding parents. The third aspect is verbal persuasion, and this really speaks to support from influential others, and that could be a partner, a parent, it can be a healthcare provider. So being supported and encouraged by people who the parent feel are influential to them. And then finally, there's the physiologic status aspect, and that really looks at if mom is feeling unwell physically or emotionally, it's really hard, or it takes away from their breastfeeding self-efficacy or their confidence in breastfeeding, because they have those kind of foundational aspects of their own well-being that aren't being met. So these 4 elements feed into the mother and her own perceptions, and then are informed by her expectations of breastfeeding. And that, in combination with her sources of information, will inform the behavior around breastfeeding. So initiation and persistence. And if a mother is efficacious or confident in breastfeeding, they tend to be more persistent with any sort of barriers they encounter with breastfeeding. And then the outcome expectations. So if they have goals that they want to achieve, that is essentially their outcome expectations. And that again works with their breastfeeding self-efficacy to look at the outcome of interest. In this case, for the study that I'm going to speak of, this was breastfeeding or human milk feeding at discharge from the NICU. So essentially that breaks down kind of the breastfeeding self-efficacy theory in one slide. So we do know that maternal breastfeeding self-efficacy is reflective of a mother's confidence in breastfeeding. We also know from research that we did in the Benzies lab with Vicare that mothers with higher breastfeeding self-efficacy will have better breastfeeding outcomes. There's extensive research to support that breastfeeding self-efficacy is modifiable. So we can act around a mother, with a mother, we can support a mother who's breastfeeding, and it can improve their breastfeeding self-efficacy, which will in turn improve their breastfeeding rates. So in turn, a mother with high breastfeeding self-efficacy is usually able to navigate barriers or setbacks more successfully than a mother with low breastfeeding self-efficacy. So essentially, they can persevere with breastfeeding longer. So in summary, just looking at breastfeeding self-efficacy theory, we know it's reflective of a mother's confidence or her perceived ability to breastfeed. It's not reflective of their actual physical ability to breastfeed, but their emotional and perceived ability. And we know that it's informed by 4 sources, and that would be performance mastery or previous accomplishments, vicarious experience or seeing or being with other people who are breastfeeding, verbal persuasion, so encouragement from influential people, and then how the breastfeeding parent or the mother is feeling. And we also know that it's modifiable, so we can act on it to help enhance breastfeeding outcomes. I'm going to talk now about a review I did of the literature looking at all the interventions in breastfeeding self-efficacy. And this study was done only in full-term infants because at the time it was conducted, there wasn't any research looking at breastfeeding self-efficacy in preterm infants. So just a little bit of a brief explainer about our levels of evidence and what we need as clinicians and healthcare providers from evidence in order to know that it's good enough to use it in practice. So when I talk about certain studies or when you read papers in the media, often it's from one single study. So a randomized control trial or a cohort study. And what a systematic review does is it searches through all the publications and pulls together all the individual studies and then brings them together to summarize them into a systematic review. So it's a study of studies. And so that's what we did with breastfeeding self-efficacy. We searched all the publications out there on breastfeeding self-efficacy. We brought them together, we summarized the findings, and then we also did a mathematical analysis to see if breastfeeding self-efficacy was actually influential on breastfeeding outcomes. So what we did is we searched 10 databases using the terminology of self-efficacy, self-confidence, self-perception. And then we meta-analyzed. So when two studies looked at the same outcome, two or more studies, we can do a statistical analysis and compile all that to have an overall or a pooled result between all the studies. And then we also did something called a meta-regression, which allowed us to take that information and determine if breastfeeding self-efficacy was predictive of breastfeeding rates in the entire body of evidence. This is just a diagram showing you how many studies we read. When we searched the literature, we found 2,400 studies. And then we actually read 58 studies and included 11 studies in our review. So these were all rejected for various reasons, didn't use tools that were accurate or didn't report outcomes that we could include. So for this study, we included 11 studies in our meta-analysis. And really what we found is that we compared moms who had a breastfeeding self-efficacy intervention. So someone was doing research on improving their breastfeeding self-efficacy and comparing it to parents who didn't get a breastfeeding self-efficacy intervention. And what we found that mothers in intervention groups reported significantly higher breastfeeding self-efficacy at discharge from the hospital 1 month and 2 month postpartum. So this tells us that breastfeeding self-efficacy is modifiable. So when we act on it and try and improve it, it actually improves the breastfeeding self-efficacy. And compared to moms or parents who didn't get any breastfeeding self-efficacy interventions, parents that did had a score of almost 5 points higher on the breastfeeding self-efficacy scale, which was the tool that's used to measure breastfeeding self-efficacy. So in general, we concluded that interventions to improve breastfeeding self-efficacy are effective at discharge from the hospital 1 month and 2 months postpartum. And then we started to look to see if breastfeeding self-efficacy actually improved breastfeeding outcomes, because it's all good to improve breastfeeding self-efficacy, but we actually care if it's actually improving what is happening with breastfeeding and if that is increasing how many parents are breastfeeding and their exclusivity. So we found that interventions that improve breastfeeding self-efficacy were also effective at improving breastfeeding rates at 1 and 2 months postpartum. And when we compared them mathematically, we found that mothers who participated in breastfeeding self-efficacy interventions were 1.56 times more likely to be breastfeeding at 1 month compared to moms who didn't get that breastfeeding self-efficacy intervention. And they were 1.6 times more likely to still be breastfeeding at 2 months. And this is any breastfeeding. And then, as I said, we looked to see if breastfeeding self-efficacy scores could predict subsequent breastfeeding outcomes. So what we saw is that for every point increase in the breastfeeding self-efficacy score, exclusive breastfeeding increased by 10%. So this is pretty profound. So like I said, when we saw the intervention compared to the control group, we had a difference of about 5 points for moms who had breastfeeding self-efficacy interventions. So they scored about 5 points higher compared to moms who were just in the standard care group. So this means for every point higher they scored, they're 10% more likely to be exclusively breastfeeding. So it can be very influential on exclusive breastfeeding rates as well. So what we learned from this systematic review was that interventions to improve breastfeeding self-efficacy are effective at improving breastfeeding rates at 1 and 2 months. And we know now that social change theories such as breastfeeding self-efficacy can influence breastfeeding behavior. And then we started to make some recommendations from that. So people who are working with breastfeeding families and researchers should think about interventions that use breastfeeding as a breastfeeding self-efficacy as a social change theory. Also, we looked at the timing of when we should be working on breastfeeding self-efficacy with families, and that postpartum period is very influential. We also found that when we do it across a combination of the hospital and the community setting, that spans those two settings, it's much more effective rather than if it's just done in the hospital or just done in the community. And also kind of intervening with families at multiple time points across their postpartum experience was much more effective than just intervening at one time point. So these are all good things to consider going forward. Now, as I said, this was only in full-term infants. And at this point, breastfeeding self-efficacy really had not been looked at in preterm infants. So what I did with my PhD is really explored breastfeeding self-efficacy in this unique population to see if this theory still held with families that had a preterm infant. So I set out to look at 2 questions. I wanted to know if breastfeeding self-efficacy was an applicable theory of in mothers of moderate and late preterm infants, and then to see if it was predictive of breast milk feeding outcomes at discharge from the NICU. So was it effective in enhancing breastfeeding outcomes? So this work was done with the Alberta FICARE or Family Integrated Care Study, which was done in level 2 NICUs across Alberta. There were 10 of them that we looked at, and 5 of them got family integrated care, and 5 of them only got regular standard care. And this was conducted from 2016 to 2019 and crossed both major centers, so Edmonton and Calgary, but also our smaller urban centers such as Red Deer, Grand Prairie, Medicine Hat. And again, this was looking at moderate and late preterm infants. So infants born after 32 weeks gestation up until 34 weeks, 6 days. We also did qualitative interviews with families. So I spoke with many families over the telephone and asked them about their experiences while feeding their baby while they were in the NICU. So I asked them about their greatest joy, their greatest worry, what they found to be most supportive, and what they found to be least supportive. And I did a thematic analysis with this data, and I interviewed 14 families across Alberta. So I'm going to talk about what we found. So first of all, looking at the results from those interviews, and we themed them out, we found that experiences with infant feeding in the NICU spanned both the NICU setting and the home setting. So first, there were really a focus around institutional influences. So the NICU environment and the rules and the policies and the procedures around feeding, that was very influential. Things like feeding schedules and things like that were very influential to the infant feeding experience, which makes sense. Another aspect that parents really spoke about was the staff and how impactful that was on their infant feeding experience, particularly the nurses. And I want to highlight this because when we get down and talk about those sources of information for breastfeeding self-efficacy and verbal persuasion, these nurses were very important with influencing breastfeeding self-efficacy. Another interesting thing that came about of this was that mom was really focused on as a milk producer. That was kind of how moms felt valued in the NICU setting. And I'm not sure if those of you in the audience can relate with that feeling. But because of that, a lot of their focus was around producing milk. And I have that connected here with this other major theme of relationship with the pump. So anyone who has been in the NICU setting knows that a lot of your time is with that pump, trying to establish your milk, to make sure that your milk supply is big enough or that it comes in, and then you can feed the milk to the baby. So that relationship with the pump goes back to producing milk. And then you can see this overlaps into the home setting because the pump comes home with you often once your baby's discharged, which talks about bringing both the pump and baby home. And this really talks also about the importance of pumping, but also direct breastfeeding, which I'll speak about in a minute. So with that relationship with the pump, and once families are discharged home, there is often a decision at this point about deciding to quit pumping. That doesn't tend to happen until the mothers or the families go home. And that's possibly because there's a lot of pressure to continue pumping while in the NICU. And also because once everybody goes home, kind of reality hits and you have a preterm infant to care for full time plus pumping. So a lot of families really around this time made that decision to quit pumping. And of course, the focus again, and we're back up into the NICU setting here, is around establishing breastfeeding. So not so much about producing milk, but establishing breastfeeding. And this goes to that latching and direct breastfeeding aspect. And this direct breastfeeding aspect was really an important predictive factor if breastfeeding continued. And we found that moms that went home pumping exclusively really struggled to continue breastfeeding compared to moms that went home who had successfully latched the baby directly. And then, of course, establishing breastfeeding and that direct feeding aspect, we're always concerned if that infant is getting enough milk because we want to know the baby is eating enough. And when you're directly breastfeeding, you can't measure it like you can in a bottle. So those were really the major themes that came out of those interviews. So what I did is I took the 4 sources of information, as you'll remember that I talked about earlier on in the presentation, and I superimposed them on these themes. Okay, so just to go back, we've got the performance accomplishments, the successful breastfeeding experiences. We've got that vicarious experience, so seeing and talking to other breastfeeding parents. We've got that verbal persuasion element of encouragement, and we have that physiologic effective, so how mom is feeling. So I superimpose them onto those themes, and I'm just going to talk a little bit about what that means and what sort of elements came out. So with performance accomplishments, looking at some of the quotes that parents provided to me, one parent said, when she being the infant, started to suck at my breast, taking the milk, that was one of the greatest things. And this really spoke to that establishing breastfeeding and the importance of that direct latch. But this was, for this parent, a performance accomplishment. It was a successful thing that contributed positively to their breastfeeding self-efficacy. Another quote in this domain was someone saying, I was trying my very, very best, but at the same time, I found it incredibly stressful because I was only making 5 mLs of milk. So that is also performance accomplishment, but kind of to the negative. So this person didn't feel like they were producing enough milk. So they kind of had a negative performance accomplishment, which would detract from their breastfeeding self-efficacy. Now moving on to verbal persuasion and thinking again what I said about those nurses. So one parent said, If it was not for the nurses in the NICU, I probably would not have been able to do this breastfeeding. The nurses being verbally persuasive, being empathetic, encouraging parents to continue breastfeeding was really very influential for the breastfeeding self-efficacy of a lot of our participants. Another parent said there was lots of encouragement to pump and maybe to increase production or what have you. So it was a lot of attention paid to pumping. This parent didn't actually feel that the support from the nurses was as good because they were so focused on pumping and producing pumped milk, which the parent felt a little bit devalued about that. But again, so we have to be wary of or aware of how our verbal persuasion comes across with families. Next, we looked at physiologic effective. And this was really interesting because it did not become apparent or did not kind of emerge from the data until parents went home once their baby was discharged. So this was really in the home setting. And one parent said, I stopped breastfeeding her. I pumped. I weaned myself off the pump and we switched her to formula because I was done. I was an absolute mess. And this parent was really struggling with their own mental well-being, but also their physical exhaustion. So this speaks to the importance of that physiologic affective state and how that impacts this parent's breastfeeding self-efficacy and breastfeeding success. And then finally, we looked at that vicarious experience piece here. And we actually found no evidence of vicarious experience in our interviews with parents. So this was interesting because, and it was pre-COVID, I just want to indicate that. So we still had parents coming, going off the NICU as they needed, as they wanted. There were pumping rooms, but none of these parents, even when specifically asked, talked about seeing other parents breastfeeding or pumping or sharing any experiences with other breastfeeding or pumping parents. So this was notably lacking from the sources of information for breastfeeding self-efficacy. So to summarize our findings from this qualitative piece, we found that except for vicarious experience, we did see that maternal experiences with infant feeding in the NICU did relate to breastfeeding self-efficacy theory. And we determined from this that breastfeeding self-efficacy theory may be applicable to consider when working with mothers of moderate and late preterm infants who are hospitalized in the NICU. But we also wanted to quantitatively assess or measure the actual impact that breastfeeding self-efficacy had on breastfeeding outcomes. So what we did is we again went back to the FICARE data and we compared parents who did not get FICARE to parents who did get FICARE to see, this was only in the control group. So nobody got FICARE here. This was just in our control group, standard care parents. And we looked at their breastfeeding self-efficacy scores when they were admitted to the hospital. And then we looked at if they were still breastfeeding or providing human milk when the infant was discharged. So there are 221 parents in this group. And we stratified infant feeding, which was the outcome of interest, into exclusive human milk or breast milk feeding and combination feeding. So this would be any formula introduced. So only human milk, compared to human milk with some formula or completely exclusively formula fed. And we actually only had 4 infants in this group that were exclusively formula fed. And what we found here is that parents who were exclusively feeding human milk or breast milk to their infant at discharge had breastfeeding self-efficacy scores that were almost 9 points higher at admission compared to parents who were mixed feeding their infants at discharge. So these parents were actually coming into the hospital setting with higher self-efficacy that were exclusively feeding their infants at discharge. So an interesting finding there. So we looked to see what other aspects of the parental well-being or what demographics or what have you would also inform exclusive breastfeeding at discharge. Because we actually wanted to know, is breastfeeding self-efficacy predictive of breast milk feeding outcomes at discharge? And we found that breastfeeding self-efficacy at admission was one of 3 significant predictors of exclusive breast milk feeding at discharge. We also found that maternal age was really important if they were born somewhere else than Canada, and if they had diabetes. So these were all important predictors. Actually, sorry, maternal age was not important. It wasn't significant. But being born in Canada was significant. Diabetes was significant. And this breastfeeding self-efficacy at admission was significant. These were the only 3 things that predicted exclusive breast milk feeding at discharge. And we also found that for each point increase in breastfeeding self-efficacy at admission, the odds of exclusively breast milk feeding at discharge increased by 4%. So not quite so much as in the full term population. So each point difference resulted in a 10% increase in exclusive breast milk feeding. But here it was still important. It was a 4% increase. So what we're seeing here is that we are seeing evidence of breastfeeding self-efficacy theory being important and meaningful in families with preterm infants. Now, when we did tease this out a little bit more and looked at moderate versus late preterm infants, moderate being infants born between 32 and 34 weeks, and then late being 34 weeks and after, we saw that it wasn't as important or impactful in parents of moderate preterm infants, and much more influential in parents of late preterm infants. And this does make sense, because if you think of a late preterm infant compared to a moderate preterm infant, there's a lot more complexities with a moderate preterm infant. And we know as gestational age increases, their ability to feed at the breast improves. There's less difficulties with feeding. So I think that parents actually, their own ability to feed their infant in a late preterm infant is much stronger and less interventions from the healthcare system. So their efficacy is actually much more informative. Whereas if those moderate preterm infants, there's a lot of interactions with the healthcare system as well as the parents. So maybe less control there. But I think this is really important for healthcare providers to be aware that when we have a clinically unstable infant and we tend to be protective over them, that this protectiveness may actually be detrimental to a parent's ability to successfully feed their infant and may be detrimental to their own breastfeeding self-efficacy. So just to summarize this last section, we really came to the conclusion that breastfeeding self-efficacy is an effective change theory for mothers of moderate and late preterm infants. We understand now that breastfeeding self-efficacy is predictive of breast milk feeding at discharge from the NICU, especially exclusive breast milk feeding. But we do need to do more research to look at breast milk feeding rates beyond discharge, because we only collected those at discharge. And does that sustain until 2, 4, 6 months and what have you? And we actually have a master's student looking at that right now. And a bit of a spoiler, they did find that breastfeeding self-efficacy does help. So parents that have higher breastfeeding self-efficacy, it looks like they are more likely to continue breastfeeding for longer. So now let's think about some practical ways that we can support breastfeeding self-efficacy in families who are in the NICU with their infant. I want to bring us back to these 4 sources of information around breastfeeding self-efficacy theory, because I'm going to break down these recommendations with regards to those 4 sources of information, and then kind of tack on an awareness of that premature infant and how that plays into what we can consider. So thinking about performance accomplishments, and I know there's clinicians in the audience and there's also parents in the audience. So parents, I just want you to think about these in ways of being aware of how interactions with clinicians can be helpful for your breastfeeding self-efficacy or hurtful for your breastfeeding self-efficacy. and perhaps ways that you can advocate for yourself around that, or even just that awareness of, okay, what this person is saying is not helpful to me. And clinicians, I want you to think about when you're talking to people about breastfeeding or infant feeding, ways that your interactions with people and your care can help with their breastfeeding self-efficacy, or ways that maybe previous practices may have hindered that. So first, focusing on performance accomplishments. Really celebrating those wins and those successes, no matter how small they are. So something such as a skin-to-skin session where the infant licks and sniffs, highlighting that, telling them that the infant is interested in the breast. Maybe if a mother had a painless pumping experience or a positive latching experience, the baby doesn't necessarily have to take milk, or the parent doesn't necessarily have to pump milk, but just the painless aspect of that could be highlighted as a positive. And expressing drops of colostrum, even 1 or 2 drops, getting very excited and celebrating that. And what I recommend is when we are working with families around infant feeding or any aspect, is really using that sandwich theory when you're providing feedback. So starting with a positive comment or a celebration, praising their strengths of what they've done well. If there's something that they need to improve on or change a little bit, entering that into the conversation at that point. So that constructive criticism piece or suggestion. Then reiterating their strengths and what they're doing well, and then offering support for them to address that constructive criticism piece. So if you've made a suggestion, offering them support to enact that suggestion. So really focusing and celebrating those performance accomplishments, and then situating any sort of improvements or suggestions within those successful experiences. So really considering what this means for the preterm population, I've provided a couple of examples with that licking and sniffing, but things that you can focus on for performance accomplishments are direct breastfeeding is huge. Pumping amounts of milk, and I have an asterisk here because that was a good and a bad thing, because moms that produce lots of milk really felt big amounts of performance accomplishments, but moms who struggled with that really felt defeated, and that their whole value as a mother in the NICU was reduced because they weren't good milk producers. So if you are focusing on that amount of milk, and maybe you don't have someone who is successful in producing milk, focusing on other elements rather than how much they're pumping. And with that, I suggest other mothering accomplishments, like look how calm your baby is with you when you're holding them, or when you put your hand in their isolette. So focusing on benefiting or increasing their own self-efficacy around parenting rather than breastfeeding if that's a struggle. So really letting them come into that role of mother from other aspects other than infant feeding. And then, of course, emphasizing and normalizing stage appropriate and realistic expectations. If you have a 31-weeker or a 28-weeker, and mom's frustrated because there's no direct breastfeeding, of course, that is really not an overly realistic expectation. So really couching your support around what is realistic for that baby at that time. Again, not limiting their abilities as well. So next, talking about this verbal persuasion. And again, I want to remind you that nurses were highlighted over and over with our parent participants as being the most influential people for verbal persuasion with breastfeeding self-efficacy. So if you are a nurse in the audience, really thinking about the role and the influence you can have with a family in the NICU around their infant feeding experience. So encouraging a mother or a parent to believe that they can succeed or continue with breastfeeding. Again, couching that with pushing them to continue against their own mental health is something to consider and be wary of, but really being there as a source of support and a positive force to encourage that continued breastfeeding. What research shows is that this verbal persuasion is much more effective coming from those with higher status or those who are respected. And like I said, those nurses really came out of the research as the key people that are important, more so than lactation consultants, more so than doctors. And likely it's because nurses are with the families all the time, 24/7. They are the go-to people. So they have that established relationship with the families. And I think it's that trust aspect and relationship that really makes them that much more influential. And then that last point there, just being aware of pushing the mother to breastfeed, because that did, of course, come out in some of our study or some of our interviews, indicating that sometimes it just became too much, that verbal persuasion. So being aware of supporting human milk feeding, but also aware of that holistic aspect of maternal mental health and when it's getting to be too much, and balancing that as a clinician to make sure that you're supporting the family the best you can. So considering the preterm population, using our skills as nurses to have therapeutic conversations. So, not really saying you should breastfeed or breastfeeding is good because of this, but using triadic questioning or empathy, different skills that we have when we work with families to have good conversations and get down to how the experience is going for the family, what's working for them, what's not, and figuring out those elements of what's going well with the infant feeding experience so that you can help work on positives and address maybe some negatives to enhance their breastfeeding self-efficacy. Using encouragement that's specific to mother's needs, so doing a personalized care, patient-centered care aspect. Also being aware of the barriers unique to that family. They will change with different families. So being aware and trying to address those barriers or even acknowledging them helps with self-efficacy. Again, emphasizing the benefits of human milk for the preterm infant. That's always a big selling point. Again, balancing that with the mental health and stress it can place on parents. So being able to read that situation. And again, emphasizing those stage appropriate recommendations and performance accomplishments again, but balancing that with realistic expectations. So vicarious experience, this is the one element that we did not see come out of our research. So this was notably absent in the NICU settings, at least here in Alberta. So as clinicians, as parents, we need to be aware that this could be something, a very important piece of support or information that is lacking for parents. And this became even more challenging during COVID. So really thinking as a clinician or as a parent, expanding your network so you can get more vicarious experience or exposure to people who are feeding their preterm infants. That can be through visual resources and videos to explain and support breastfeeding. Now, as we're getting into this peri-pandemic time, hopefully we can start again with peer breastfeeding groups. Those don't necessarily need to be in person. They can be in an online forum or a video setting. Really encouraging interaction with people who have had positive feeding experiences. Really, I say positive because if you're coupling or encouraging interactions with people who've had negative feeding experiences, that can actually be very detrimental to breastfeeding self-efficacy. And one element of ViCare that plays into this is we bring veteran parents in who've had an experience with the NICU. And that vicarious experience piece, not just with infant feeding, but the whole NICU setting and experience is very beneficial to parenting self-efficacy and breastfeeding self-efficacy. Considerations in this aspect of vicarious experience for the preterm population, thinking about peer breastfeeding or pumping groups, either on the unit or virtually, and then extending this beyond the postnatal period. So a great example of that is the CPBF, right? Fabiana is really great at extending support and education outside of the hospital setting and out into the first, second, and even as kids grow up to become children. And there's a peer support group that's online. There's weekly education sessions. So this is a really good example of that vicarious experience. And then as clinicians and also as parents, seeking out evidence-based videos and visual information about infant feeding that's specific to preterm infants and pumping. And there's lots of resources out there, even more so now that we've been through COVID and we've moved so much stuff online. And then finally, I just want to highlight that physiologic and affective state. So really, as a nurse or a clinician, and even as a parent, being aware of how mom is feeling. And I know in the NICU setting, our emphasis and our focus is on the infant. And we often forget the parent sitting in the chair. But it's very important to incorporate our assessments to be holistic, to include the parents, because as we all say, you can't pour from an empty cup. So if mom is not doing well physically, mentally, or emotionally, they're not going to be able to breastfeed as successfully, or produce milk as successfully. So really going back, working with mom and the parents to ensure that they're feeling okay and addressing what you can help them with. So if they're in pain or if they're in psychological distress, giving them referrals, getting those needs addressed so that mom can be as strong physically and emotionally as possible to feed that infant. So consideration for the preterm population. Really, there's some interesting work that talks about Maslow's hierarchy of needs. So this is when we're in periods of stress, we only focus on what is foundationally necessary for us to survive. And then as we start to flourish, we can build relationships, we can psychologically do well, we can get more sense of attainment and more sense of well-being and success. So when parents have an infant in the NICU, specifically mothers, they are just addressing their very basic foundational needs of survival. They're not psychologically flourishing often. So this doesn't become addressed until often the infant has been discharged from the NICU and mom realizes, oh my gosh, I'm so tired, or I'm not doing well psychologically, or I'm not feeling like I'm flourishing. So just being aware of that. And like I said, addressing how mom is doing emotionally and physically. Like I said, moms are often forgotten, or parents are often forgotten. So taking a moment to sit down or address the parents and ask how they are doing. And you may not be able to address those needs, particularly as a nurse on the NICU, but you definitely have the ability to refer over to social work or to psychology or what have you if the parents are struggling. And I just want to talk briefly about what kind of interventions work. So again, this comes from that systematic review I talked about, but education interventions, so teaching about the importance of infant feeding and human milk feeding, multiple contact points. So not just a one-time touchdown, but consistently building on your interactions with parents. One thing that came out of our research was being proactive rather than reactive. And this is actually why nurses were perceived to be more influential than lactation consultants, because our model of care brings lactation consultants in when there's a problem. So it's reactive care, whereas nurses can actually see something building and address it earlier on. So really that focus on being proactive rather than waiting for a problem to happen and addressing it afterwards. Thinking about care and support that span the hospital and community setting. So as I mentioned, CPBF is a great example of that. And then targeting your care towards those 4 sources of information for breastfeeding self-efficacy. So with that, I want to take some questions now. My contact information is there. So my University of Calgary account, and I invite you to follow me on Twitter. And I just want to acknowledge for this work, Dr. Karen Benzies and the Alberta Phi Care team, as well as Ms. Samantha McLeod, who did some of the breastfeeding self-efficacy at discharge, as well as our funders, Alberta Children's Hospital, CIHR, and Alberta Innovates.
Hi, Merilee. Thank you so much for sharing this amazing work. Wow. I have a lot of questions. This is so great. And I learned so much from you. because I had no idea about the self-efficacy tool. I don't know if I can call it a tool, but I feel like it's like, this is a toolbox. Okay, which elements can we work on each stage?
Yeah.
So my first question to you is in regards to the nurses. When you are doing the study, and I think that's something that also to moving on, if you're going to implement this in ICUs across Canada, do they receive education on those 4 points? And I'm particularly interested in the communication piece.
So a lot of nursing does include that therapeutic conversation piece. Some things, like I said, like triadic questioning, and that would be asking a parent, what would your partner think about this? Or what would your partner suggest? Or having conversations about what's working for you. We do that in nursing, but in regards to all aspects of nursing, that therapeutic conversation. But what we don't get is that breastfeeding self-efficacy education. And in the NICU setting, we are now at the point where the majority of nurses do get the minimum breastfeeding education, that 20-hour course. Some are lactation consultants themselves, but breastfeeding self-efficacy is really quite a new aspect, especially in the preterm population. Here in Alberta, we've actually integrated it into our breastfeeding module for healthcare providers. So now in the coming months, all healthcare providers working with childbearing families will have to take this course, and we've infused breastfeeding self-efficacy in there.
Wow, that is great, because I feel like everybody needs that training, right? Because we know, like from our, here at the foundation, we hear a lot of families saying if they have a late preterm baby, or if they transition to a level 2 hospital with the baby, and there is this rush to get the baby home. So let's do bottle feed. There's a lot of pressure to get a baby out of the hospital, and bottle feed sometimes seems to be the way to go to get the baby out of the hospital. So I feel this is like a very important information to be disseminated among NICUs, especially level 2s, and they see these late term babies.
I absolutely agree with you. And that emphasis, I've heard that, sorry, my dog's barking. I've heard that from lots of moms anecdotally, that they are encouraged to bottle feed so they can get out of the hospital earlier. And that's something I wish we had more time to pick apart and ask if that was a standard of recommendation, because we do hear that from a lot of people. And when you're told, if you're trying, like I said, our work showed that direct breastfeeding at discharge was really important for continuing to breastfeed. But if we're pushing parents to bottle feed so they can get out of the hospital sooner, then that is very detrimental to that continued breastfeeding aspect and that self-efficacy piece. So very much agree with you, Fabiana.
So you also did a lot of work to look at the impact of the pandemic and the restrictions on the breastfeeding rates, because we've seen over the last 2.5 years, because the parents could not be at the NICU for as long as we wished. So babies got maybe breastfeeding a few times a day, and everything else was bottle feed because the parent could not be there. So do you see this being disseminating across Canada, hopefully not only in Alberta, to really also to address that? Because we don't know what's going to happen. We're coming into the fall again, and we're knowing that the numbers probably will rise again. We don't know what's going to happen with the restrictions again. We hope that we have enough evidence to keep the parents inside an ICU, but we don't really know what's going to happen. So how do you see this playing a big role to impact breastfeeding rates in Canada?
I think that's a really important consideration, and I can only speak to it theoretically because it hasn't been measured, but you're right. Having a breastfeeding parent in the hospital for as many touch points as possible, so a long period of time, is really important to enhance that direct breastfeeding piece. But the other element is that for a long time, it was only one parent. You couldn't have both in. So that partner support, which is also very important for infant feeding. Now, moving forward, I think you guys at Preterm Premature Babies Network Foundation, you're doing a lot of work around separation and the importance of that. And also, I guess, highlighting the importance of that with breastfeeding, and that breastfeeding self-efficacy, direct breastfeeding piece is also important. Because I hope we now know how damaging it is to separate parents from preterm infants. Not just for their well-being, but for the whole psychosocial aspect, and moving onwards on multiple aspects, not just feeding, but psychosocial attachment, what have you. So I think it's an advocacy piece for sure. Yeah.
Yeah, we still have a lot of work to do there, but we are not giving up on.
No, you're doing great work on it.
Yeah. Merilee, one question that you mentioned, the Vicarious Experience, which is a lot of the peer support, was didn't show a lot of impact. Is that because some of the study were doing during the pandemic, or there was not a lot of in-person peer support?
So it was all before the pandemic, which surprised me. And I did specifically ask if parents interacted with other breastfeeding parents, and they said no, which really I was surprised by that. I do know there's pumping rooms and that the parents can go in there and sit and pump, but a lot of parents just sat in their pod or in their room or beside their baby's bed. And didn't really interact with each other a lot. And I don't know if that is an Alberta context thing. This is level 2, not level 3. So it might have just been that. One thing we didn't look at is the structure of the NICU. So if it was like individual rooms versus open bay, I don't know if that would have been different. And that would have been something really interesting to look at as well. But I was very surprised by that finding.
No, I was surprised too, because for me, when I had my first son, which was a late, overdue baby, but I still went to Lactation League, and I felt really empowered and supported by other parents who were breastfeeding. So it made me to have a more purpose to breastfeed my son, because I saw their moms and the benefits. But with my preemie, he was in the hospital for 5 months. I attended all the lactation consultant classes, and having those moms around, and you were talking about breastfeeding and the challenges that we had, discussing volumes and all that, I felt really like, okay, I need to be doing this, because there was a peer support around. So I'm really surprised by these results, to be honest with you.
Yeah, it's and there's so much research showing the importance of peer support in infant feeding, and how good that is to help support infant feeding. So I think it would probably definitely look at being a deficit in care that we provide. Like I said, I don't know if that's an Alberta context thing.
Right.
It's definitely hospital to hospital, but an important area that needs to be built on some more.
Okay, so my next question to you, you talk about the moderate preterms. I want to talk about the early babies, the early preterm babies, because you say, yes, baby's not going to latch for a very long time, weeks, months, we know that. But is this applicable to parents who are embarking on this journey with pumping first? Because I feel everything that you said is applicable to pumping.
Oh, yeah, absolutely.
Right? You did mention a little bit on pumping, but it's the same concept, right? And you're setting us up for success.
Absolutely. And I think if you go back to those clinical recommendations and those 4 sources of information, it would work across any sort of prematurity stage. It's just celebrating those stage appropriate accomplishments. So if we're doing skin to skin and the infant is, smelling and relaxed and their vital signs are all stable, highlighting that skin to skin connection piece. Or like I said, if there's any sniffing or licking at the nipple, showing, look how interested they are in you, and they can smell your milk and what have you. So making those points of connection and making those interactions positive will really inform that breastfeeding self-efficacy piece, definitely. But focusing on age appropriate for sure, or stage appropriate.
Right, because we always talk also in that to talk about volumes, right? And we know like the first pump is this tiny bit of colostrum, like 1 drop. Right. And I think we don't celebrate that. And I feel that we're also guilty at the foundation because we push so much for breastfeeding, and we forget to acknowledge how important those drops of this, the colostrum is for that journey.
Yes, absolutely. Yeah, getting very excited about those first few little drops that come out and capturing those and taking the time. I've seen lactation consultants and nurses take the time to extract each drop into a syringe. And that shows the parent the value of those drops and what they're producing and how important it is for their infant. Again, a performance accomplishment, right?
Absolutely. So you mentioned mental health, and I need to ask you that because this is such a big piece. And World Breastfeeding Week just passed in August. We had a lot of conversation on social media about breastfeeding, and a lot of parents send us messages that they felt very guilty that they couldn't. They felt pressured and they felt like a failure because their bodies didn't produce milk, or they couldn't for the physiological reasons that you mentioned. So how do we, and you talk about this balance, so how do we find that balance where in the NICU, for whatever gestational age it is, right? We find a balance that, this is very important for your baby, but your mental health is also very important because you're going to live with this baby for the rest of your life, right? You have to have parenting skills and patience and everything that comes with parenting and our worries. So how do we balance that and make the parents don't feel guilty if they absolutely can't or choose not to?
Yeah. And that is so challenging on multiple aspects. So I think from a healthcare provider's aspect, being very aware, taking the time to have those conversations, to do that maternal assessment and be aware if mom is not coping and this is so stressful for them, right? And having conversations around maybe making some provisions for, okay, so maybe it's not exclusive your milk. Let's get some donor milk on board. And then the other aspect is highlighting what has gone well. So did they get some drops of colostrum? We have lots of research to show if a baby isn't breastfed and they get colostrum, they have good outcomes. And that colostrum is really important. And if that's not possible, then we have donor milk. Mm-hmm. And a lot of moms, anecdotally, we need to look at this more, do feel a lot less stress when their infant gets donor milk instead of formula milk, because it's almost as good. It's not quite as good as mom's own milk, but it's still so much better, right? So the fact that we're able to offer donor milk to almost all of our preterm infants is so good. And we can emphasize that. Like, they've gotten so much good stuff from this. So the positives, and really allowing parents to take that forward to help with their guilt. But it's so challenging, Fabiana. I agree with you. It's balancing that emotional health and stress and guilt with feeding human milk.
Yes, and coping with an ICU is so challenging, and everything comes together, and so many times, more than not, it's a surprise.
Yeah,
right? That you end up in an ICU with your baby, and I shared this many times, like when I delivered my baby at 26 weeks, and the nurse came in with the double breast pump and said, "You got to start pumping." I was just recovering from a C-section, like, what, I want to breastfeed my child, and I had no idea how even he looked like, because I hadn't seen him yet.
And that is not unusual. So many parents have the pump come to them before they see their baby. Like, that is profound, isn't it?
Yeah, and absolutely, and you have other expectations, right? Like, okay, because I had a term baby before, I said I want to breastfeed him right away, but I had no idea. Right. And then, yes, I did see the pump before I saw my own child. So we have lots of work to do on the mental health piece of supporting NICU parents. We are very aware of that. And I'm so happy that you're working on this project that involved that one piece as well of communication and how do we support the lactation parent better. So Merilee, thank you so much for joining me here today. So nice to talk to you, to learn about what you're doing and what you're working on. You have so many interesting projects on the go, and I'm so grateful to have you doing this work. And I do hope this is this goes beyond Alberta because we need this across Canada. Actually, we did have an audience from Chile today and from Pakistan. So, why not expand it to worldwide, right? Good work has to be extended.
Thank you for the opportunity, Fabiana. I really appreciate speaking to you and your audience.
Thank you, Merilee. And to all of you watching us live today, thank you so much for joining this session. And the video of today's session and all the other videos from our Preemie Chat series is available on our website or YouTube channel, which is right here, the Canadian preemies.org. And I want to thank our sponsor, AstraZeneca, for the ongoing support of our education sessions. And we are a charitable organization, and we believe that through support and education, we can empower families, ensuring they are ready to care for their babies. Please visit our website, consider making a donation. Together, we can create a brighter future for all our families. And I see you again next Friday, 1 p.m. Eastern Time. Stay well.